Hello everyone. So today we are going to be starting with rectus sheath. This is a very important topic and it has been asked as a 10-mark question as well as a 5-mark question in the previous university exams. So here is the question. Describe the rectus sheath under the following headings. That is its formation at different levels, the contents and the applied anatomy. We will be learning about the complete rectus sheath in this video. So the first thing first is, what is rectus sheath? The rectus sheath is an aponeurotic sheath enclosing the rectus abdominis muscle and the pyramidalis muscle if it is present on either side of linea alba. So let me just go back to this pic. So this you can say is the linea alba, okay? So on either side it encloses the rectus abdominis muscle. So that is nothing but your rectus sheath. Okay, it is an aponeurotic sheath enclosing the rectus abdominis muscle on either side of linea alba. But how is it derived from? Where is it derived from? See, it is derived from the flat muscles, that is external oblique, internal oblique, as well as the transverse abdominis of the anterior abdominal wall. These three muscles, as you all know, these three muscles form the anterior abdominal wall. They are nothing but your external oblique, internal oblique, and transverse abdominis. From these three muscles only rectus sheath has been derived. So let us look into some of the functions of the rectus sheath. It helps in checking the bowing of the rectus abdominis muscle during its contraction and hence increases its efficacy. So what does it basically do? It helps in checking the bowing of the rectus abdominis muscle, okay, and it increases its efficacy, and it also helps in the maintaining the strength of the anterior abdominal wall. So therefore rectus sheath is very important. First, what does it do? It checks in the contraction. It checks the contraction of the rectus abdominis muscle and also increases its efficacy. Along with that, it also helps in maintaining the strength of the anterior abdominal wall. Okay, so this is one diagram that you all need to know. If you know this diagram, everything else is very easy. So this is nothing but a sagittal section of your abdomen. Okay, so this green color thing, what you can see, it is nothing but your anterior wall of the rectus abdominis. Okay, and this thing is the posterior wall of your rectus sheath. See, this is also the anterior wall of the rectus abdominis, or you can also say this is the anterior wall of the rectus sheath. Okay, this is complete. Okay, and this is your rectus abdominis muscle. This brown color is rectus abdominis muscle. This anterior wall of the rectus sheath has been, tightly, it is adherent, kind of, you can say, to the rectus abdominis muscle with the help of these tendinous insertions. Okay, and as you can see, the anterior wall is full, it is complete, but the posterior wall, as you can see, it is deficit. So this is deficient. Okay, this is very important. And the lowermost point of the posterior wall, where the posterior wall ends, is nothing but your arcuate line. So this is the most important when we go about to learn about the formations. So here we will discuss about the arcuate line. So this is very important to know about the arcuate line. So what is arcuate line? It is nothing but the end point of your posterior wall of rectus sheath. Okay, so these are the costal cartilages above. You have the diaphragm. This is nothing but your diaphragmatic fascia. This is your fascia transversalis. This green color is the posterior wall of rectus sheath. These are here you can see two arteries. That is, this is your superior epigastric artery, and this is your inferior epigastric artery, which will form some anastomosis also. So the features, moving on to the features, the rectus sheath, it presents the anterior and the posterior walls. Yes, as you can see in the above diagram, it has the anterior wall as well as it has the posterior wall. The anterior wall is complete, but the posterior wall is deficient. The anterior wall is complete, see, and it covers the entire extent of the muscle longitudinally from the upper end to the lower end. I hope this point is clear to all of you, that the anterior wall is complete and it covers the entire extent of the muscle. Yes, this brown color is the rectus abdominis muscle. It covers the entire extent from the upper end to the lower end. The posterior wall is deficient above as well as below, because above, what do you have? Above the posterior wall, you can say you have the costal cartilage. Below you don't have anything. You directly have your fascia transversalis. Okay, so the posterior wall is deficient above as well as below, and it does not cover the entire extent of the muscle longitudinally. So above, it is attached to the costal margin. What do you mean by costal margin? It is nothing but the costal cartilage of 7th, 8th and 9th costal cartilages. They are only called as your costal margin. 7th, 8th, 9th costal cartilages, and thus the muscle is directly on the 5th, 6th and 7th costal cartilage. See, above it is attached the rectus, the posterior wall of the rectus sheath. Above it is attached to the costal margin, and thus the muscle, it lies directly on the 5th, 6th and 7th costal cartilage. The muscle lies directly on the 5th, 6th and the 7th costal cartilage because it is attached to the costal margin. The posterior wall is attached to the costal margin. Okay, on the costal cartilage. Moving on, below it presents as a free curved margin with concavity facing inferiorly called the arcuate line. This is also known as line of Douglas between the umbilicus and the pubic symphysis. Below this level, the muscle lies directly on the fascia transversalis. So, what is arcuate line? Arcuate line, first of all, it lies between your umbilicus as well as the pubic symphysis, and it presents freely. See, it is a free curved margin with concavity facing inferiorly. So, this is not that, like, to understand, it's not very helpful, this sentence, but what is helpful is it lies between your umbilicus and the pubic symphysis, and you can say that the arcuate line is nothing but the end point, like it's the lowermost part of your posterior wall of rectus sheath. So this line only, we call it as arcuate line. Okay, and that is your arcuate line. Below this level, the muscle lies directly on the fascia transversalis, as you can see also here. This below the arcuate line, below this, the muscle lies directly on this blue colored thing, that is nothing but your fascia transversalis. So in the above diagram, yes, in the above diagram we can see that the anterior wall of rectus sheath is firmly adherent to the tendinous intersections of the rectus abdominis, whereas the posterior layer is free from the muscle. Moving on to the formation. So this is very, very important. So the formation of the rectus sheath differs from above downwards as follows. Okay, so first we are looking at above the level of costal cartilages, above the costal margin, you can say. So above that, we just saw that the muscle posteriorly, what is it? The anterior wall, posteriorly it lies directly on your costal cartilages. Okay, see the posterior, this is the posterior side and this is the anterior side. We have taken a section at the level of costal cartilages. So anteriorly only one muscle is formed. Like if you go and look at the origin as well as insertion of the external oblique muscle, right, you will realize that this is the only muscle that is arising, like it arises from your costal cartilages. So when we take an intersection of like the costal cartilages, you will see the only muscle that we can see will be the external oblique muscle. So for the external oblique of both sides, they will form the aponeurosis. So the anterior wall is formed by external oblique aponeurosis, and posteriorly we do not have anything. The muscle directly lies on the costal cartilages. These two are nothing but your rectus abdominis muscle. Okay, so above the level of costal cartilage, the anterior wall is formed by the aponeurosis of external oblique only. Posteriorly, you have the costal cartilages, nothing else you have. So now if we look at this, above the arcuate line, but where? Above the arcuate line, it can be anywhere. No, above the arcuate line, that is, it is between your, like it is below the costal margin and the arcuate line. So that section we are looking at, it is between your costal margin and the arcuate line. Okay, so over there, if we take a section, if we take a transverse section, we can see something like this. Now you will be able to see all the three muscles, that is the external oblique, internal oblique as well as transverse abdominis on both the sides. Okay, and so now what happens is, from same like before, from the external oblique, you have the external oblique aponeurosis coming from both the sides. They will form your anterior wall. Now in internal oblique, what happens? It will split into two parts. Okay, it will form here it forms the anterior lamina of internal oblique. This is the posterior lamina of internal oblique. The same happens over this side also, anterior lamina of internal oblique, posterior lamina of internal oblique. And then you have the transverse abdominis aponeurosis, and behind this pink color is nothing but your fascia transversalis. So you need to remember this diagram. At above the arcuate line, in bracket you need to write that it is nothing but between your costal cartilages and your arcuate line. Okay, so there when you take a cross section, these are the things you can see. It's the same. From external oblique, you get external oblique aponeurosis. From transverse abdominis, you get transverse abdominis aponeurosis. Over here, internal oblique splits into two parts, that is your anterior lamina as well as posterior lamina. So now looking at this diagram, it is very easy to write down the anterior wall. The anterior wall is formed by the external oblique aponeurosis. Yes, as you can see, this number 1 I have written, right? These two. like these two it will include. This part, it includes the external oblique aponeurosis, and next is the anterior lamina of internal oblique aponeurosis. The posterior wall includes this entire length. That is nothing but, yes, first one is the posterior lamina of internal oblique, the transverse abdominis aponeurosis, and your fascia transversalis. We'll see if that is what is written. Posterior lamina of internal oblique aponeurosis, transverse abdominis aponeurosis, fascia transversalis. So this is what happens at the level of, like, above the arcuate line, that is between your costal cartilages and costal margin and arcuate line. So below the arcuate line, if you look, as we saw even in that diagram, that below the posterior wall was deficient, that is below the arcuate line, what will happen? The muscle lies directly on the fascia transversalis. So fascia transversalis is your posterior relation. Okay, now what happens over here? Look, below the arcuate line, external oblique aponeurosis is there as normal. Now what happens? Your internal oblique as well as your transverse abdominis, they both join together and they form a common tendon, that is known as your conjoint tendon. So this is very important. Conjoint tendon is, we can see it below the arcuate line. Okay, so the internal oblique and your transverse abdominis will join together and they form common tendon, that is conjoint tendon. So the anterior wall is formed by external oblique aponeurosis as well as conjoint tendon, that is nothing but internal oblique and transverse abdominis at the site of insertion. Posterior wall, it is deficient, so therefore it lies directly on your fascia transversalis. Okay, so let us just revise once so that you learn it here only. The formation of rectus sheath differs. Okay, it is different at different levels, and from above downwards we are going. First, if we take a cross section at the level of costal cartilages only, of like full above, if you take a transverse cross section, you need to imagine it, and once go and look at the external oblique muscles in origin and insertion. Okay, then you will be able to understand it even more better. So if we take a transverse cross section that much above, the only muscle that you will be able to see is your external oblique. So in the anterior wall we have the external oblique aponeurosis, posteriorly you have nothing, or you can say we just have the costal cartilages. Next, if we take a cross section between the costal margin and the arcuate line, you will see that over here you have to remember internal oblique muscle splits into two laminas, anterior lamina and posterior lamina. Draw everything else as the same, and then you can write the anterior relation as well as the posterior relations of it. Below the arcuate line, if you see, you know that posterior wall is deficient, so it will be fascia transversalis in the posterior wall. Anterior wall, you need to remember that there will be formation of conjoint tendon. Internal oblique as well as transverse abdominis both together will form this conjoint tendon. Therefore, we can write in the anterior wall relation, it is formed by external oblique aponeurosis as well as your conjoint tendon. So what is arcuate line? Just to tell it to you again, it is the lower border of the posterior wall of rectus sheath. It lies between umbilicus and pubic symphysis. If you know what is arcuate line, then everything else will be very clear to you. If you know what is arcuate line, first section, so we took at the uppermost layer, like above-most we took costal cartilages at the level of costal cartilage. The second one we took was between your costal margin and arcuate line. And the third one was below arcuate line. So if you know what is arcuate line, everything else is very easy. Now coming to the contents, what are the contents of your rectus sheath? Okay, it encloses two muscles. Yes, as we told in the definition only, it encloses two muscles. First one is rectus abdominis muscle, and second pyramidalis, if it is present. So in some people pyramidalis is present, in some people it's not present. So according to it, it encloses two muscles. It encloses two arteries. This is also very easy to remember because I showed it to you in the first diagram itself, that there is anastomosis of superior epigastric artery as well as inferior epigastric artery. Moving on to the two veins, the same only. These only make it into vein and right. Superior epigastric vein, inferior epigastric vein. And it encloses 6 nerves, okay? Thoraco-abdominal nerves, that is from T7 to T11. All these nerves will come under your rectus sheath. So thoraco-abdominal nerves and your subcostal nerve, that is T12. So now relevant features of the contents. What are the relevant features of these contents of the rectus sheath? So first we learned that superior epigastric artery is a content. So we will study a bit more about this. That is, it is a branch of your internal thoracic artery. Okay, internal thoracic artery gives branch to superior epigastric artery, and this artery enters the rectus sheath by passing through the gap between the costal and the xiphoid slips of the origin of the diaphragm and passes deep to the rectus abdominis. How does it pass? If we go up, we'll see if we can look at this. See, this is your superior epigastric artery, right? Superior epigastric artery, this artery is your superior epigastric artery. It is somewhere, it is coming between your diaphragm. See, here is your diaphragm and probably the costal cartilage. It is slipping between this gap and it is coming. That is what they are telling over here also. So it enters the rectus by passing through the gap between the costal and xiphoid slips of origin of the diaphragm. That is nothing but costal and the diaphragm, and passes deep to the rectus abdominis. The next artery we have is the inferior epigastric artery. It is a branch of external iliac artery, okay? And it enters the sheath by passing in front of the arcuate line. It enters the sheath by passing in front of the arcuate line. So both these arteries anastomose with each other within the sheath and supply the rectus muscle. Okay. So next is the superior epigastric vein. It accompanies your superior epigastric artery and it drains into your internal thoracic vein. Superior epigastric vein, all they are saying is that superior epigastric vein, where does it drain into? It drains into your internal thoracic vein. Superior epigastric artery, from where was it? Is a branch of what? Internal thoracic artery. Similarly, this vein also goes and drains in where? Internal thoracic vein. The inferior epigastric vein, this also accompanies inferior epigastric artery and it drains into your external iliac vein. So it's the same. It's the same. See, external iliac arteries branch is inferior epigastric artery. Similarly, your inferior epigastric vein will drain where? External iliac vein. Just change everything into vein. The superior epigastric artery is a branch of internal thoracic artery. Similarly, this superior epigastric vein will drain into your internal thoracic vein. So you can remember it very easily. So now moving on to the last part of this rectus sheath, that is the clinical correlation. This is not that important, you can just write it and come. The pedicle flap of the upper part of the rectus abdominis muscle is based on the superior epigastric artery, is commonly used in reconstructive surgery of the breast. So the upper part, they are saying that the in the upper part of the rectus abdominis muscle, where superior epigastric artery is present, there it is commonly used. There is a pedicle flap over there in the upper part of the rectus abdominis muscle, which is used in reconstructive surgery of the breast. Okay. Next is the diversification. What is this? Yes. So next is the divarication of the recti muscles. Okay, that is nothing but separation of the recti abdominis muscle. It usually occurs in elderly multiparous women with weak abdominal muscles. It usually occurs in elderly. Multiparous means, what do you mean by multiparous? A woman who was given birth to more than one child is known as multiparous. Okay, a woman with weak abdominis muscles. See, yeah, because she has given birth to more than one child, it might have happened that she has weak abdominal muscles and she's elderly also. So in such people, we can see that there is separation of the recti abdominis muscle. The aponeurosis forming the rectus sheath becomes excessively stretched. Consequently, when the patient coughs or strains, recti muscles separate widely. That is, so first of all, she has, or that person has weak abdominal muscles. On top of that, what is happening? Your aponeurosis is becoming excessively stretched. Okay, that is, your rectus sheath is becoming excessively stretched. So when there is increase in intra-abdominal pressure, such as if the patient coughs or if she strains, or if they strain, the recti muscle will separate widely. A hernial sac containing the loop of intestine protrudes forward between the medial margins of the recti. As you can see in this diagram, the rectus abdominis muscle, see, it is splitting. Okay, from here there can be herniation of loops of intestine on the medial margins of recti. This is the medial part, right? So on the medial margins of the recti muscle, you can see that there can be like splitting of the recti, and that can also lead to herniation. The next clinical correlation is about the hematoma of rectus sheath. Sometimes the superior and the inferior epigastric arteries are are unduly stretched due to a severe bout of coughing or in later months of pregnancy and ruptures. So what happens here also, see, why are we telling coughing or later months of pregnancy only? Why not other things? Because these are some of the things which will lead to increase in intra-abdominal pressure, because of which what is happening there, these arteries are getting unduly stretched and they can also rupture. Because of stretching they can also rupture, and now if exposed to blunt, or it can also be that it will rupture if it is exposed to blunt trauma to the anterior abdominal wall, leading to the formation of hematoma within the rectus sheath. Okay, so what is happening basically is your anterior abdominal wall is there, either there is severe bouts of coughing or pregnancy, or there is a blunt trauma to the anterior abdominal wall. All these are nothing but there's increase in intra-abdominal pressure, because of which what is happening, there is stretching of your superior and inferior epigastric arteries, which can also lead to rupture, because of which a hematoma is formed within the rectus sheath. Clinically, it presents as a midline abdominal pain. Clinically, now if a patient who is either having severe bouts of cough, or a patient who is in later months of pregnancy, or somebody who has been exposed to blunt trauma to the anterior abdominal wall comes to you in the OPD, how will she present with? She presents with a midline abdominal pain and a tender mass confined to one of the rectus sheath. Okay, so this is how they present with. Now if some of you do not know what a hematoma is, it is nothing but localized collection of blood outside the blood vessels, okay, often due to an injury such as trauma or anything like that. That is called hematoma. It is localized collection of blood outside the blood vessels. The next and the last clinical correlation, I think, is the epigastric hernia. All of you know where the epigastric region is, right? I have already explained the quadrants of the abdomen, and epigastric is present here. This is the epigastric region. Okay, so the linea alba, a midline fibrous raphe, is formed by interlacing of aponeurotic fibers of three paired flat muscles of the anterior abdominal wall. This point is not that important, that just talking about linea alba. And what is it? Linea alba is nothing but a fibrous midline raphe, okay, that is present in your abdomen, and it is formed due to aponeurotic fibers of these three paired flat muscles, okay, that is your external oblique, internal oblique, and transverse abdominis. It extends from your xiphisternum to the pubic symphysis. Okay, just check once if those are only the three flat muscles. I'm pretty sure they are, but I want you guys to check it also. So it extends from your xiphisternum to the pubic symphysis. What is this? This is your linea alba extending from xiphisternum to your pubic symphysis. It is wider, about 1 centimeter above the umbilicus, and very narrow below the umbilicus. Now if here is umbilicus, what is happening is this linea alba, it is wider, that is about 1 centimeter above the umbilicus, and below the umbilicus it is very narrow. Again, in elderly multiparous women and chronically ill children, what is happening? Linea alba becomes very weak. So it is becoming weak, okay? And when there is increase in intra-abdominal pressure, the extraperitoneal fat may protrude through the upper part of the linea alba, because see, it is however wider also, and it has 1 centimeter gap also. Now because it has become weak, first thing, and second, there is increase in intra-abdominal pressure, what will happen? What is present inside, that is the extraperitoneal fat, may protrude through the upper part of the linea alba. It may also drag behind it a small peritoneal sac, which may contain a portion of the greater omentum, forming epigastric hernia. So nothing in this. So in epigastric hernia, what will you actually write? You will write what is linea alba. First of all, it is a midline fibrous raphe, okay, and it extends from your xiphisternum to your pubic symphysis, and you will write it is wider above the umbilicus, about 1 centimeter above the umbilicus. It is wider, it's not 1 centimeter wide, sorry for that. It is wider, about 1 centimeter above the umbilicus, and then it is very narrow below the umbilicus. And what is happening when in elderly multiparous women and chronically ill children, it becomes weak, because of which if there is increase in intra-abdominal pressure, extraperitoneal fat may protrude through the upper part. Along with it, it may also drag a small peritoneal sac, which may be a part of your greater omentum, which will lead to formation of epigastric hernia. As you can see in this picture, epigastric hernia is formed because of protrusion of fat. So this is it about your rectus sheath, its formation, contents and clinical correlation. This is a very short and nice topic. If this comes, you guys need to score well. So thank you for watching. Thank you for watching.